Your hospital has a fall prevention policy. Every hospital does. It probably requires fall risk assessments on admission, every shift, and after certain medications. It probably requires bed alarms for high-risk patients and hourly rounding. On paper, it's solid. In practice, it's failing. And when a patient falls, that policy doesn't protect your hospital. It becomes the plaintiff's primary weapon. Here's why. Most hospitals treat their fall prevention policy as a checkbox exercise. The policy exists, the EHR has the fields, nurses are trained on it during orientation, and leadership assumes that because the policy exists, it's being followed. But there's a massive gap between having a fall prevention policy and having documentation that proves it was executed. That gap is where seven-figure lawsuits live. Let me show you exactly what I mean. Let's break down what a typical fall prevention policy actually requires, and I want you to think about whether your charts consistently show documentation of every single one of these elements. First, a fall risk assessment on admission using a validated tool like the Morse Fall Scale. Second, reassessment every shift, typically every 8 to 12 hours. Third, reassessment after any change in condition, after surgery, and after administration of medications that affect balance or cognition. That includes narcotics, sedatives, and blood pressure medications. Fourth, interventions matched to the risk level. High-risk patients get bed alarms, non-slip footwear, call light within reach, and hourly rounding. Fifth, documentation that each intervention was implemented, not just ordered, implemented. That's 5 categories of required documentation, every shift, for every patient flagged as a fall risk. Now here's what the chart actually looks like in a typical fall case. Patient admitted at 2 p.m., fall risk assessment completed on admission, score of 16, high risk. Interventions ordered, bed alarm, non-slip socks, hourly rounding. So far so good. Evening shift starts at 7 p.m. No reassessment documented at shift change. Nurse administers 4 milligrams of morphine at 11 p.m. for post-surgical pain. No fall risk reassessment after the narcotic. Hourly rounding log shows entries at 8 p.m., 9 p.m., and 10 p.m. Then, nothing. No entries at 11, midnight, 1 a.m., or 2 a.m. At 2:15 a.m., the patient is found on the floor next to the bed. The bed alarm was not documented as activated at any point during the shift. A plaintiff attorney looks at that timeline and sees a case that writes itself. They don't even need a medical expert to explain it. They pull your fall prevention policy, they put it next to the chart, and they count. Shift change reassessment, required by policy, not done. Post-narcotic reassessment, required by policy, not done. Hourly rounding, required by policy, stopped 4 hours before the fall. Bed alarm activation, required by policy, never documented. 4 policy violations, 1 shift, 1 patient, 1 fall. That's not a medical judgment call. That's a checklist your own hospital created and your own staff didn't follow. Any jury can understand that. And here's what makes fall cases so dangerous for hospitals. Juries don't need medical degrees to understand them. They understand alarms. They understand hourly checks. They understand that someone was supposed to look in on a patient and didn't. Fall cases are the easiest medical malpractice cases for a plaintiff to win because the standard of care is written in plain English in your own policy. Let's talk about the narcotic reassessment gap specifically, because this is the single most common documentation failure in fall cases. A patient is identified as a fall risk. 4 hours later, a nurse administers morphine or Dilaudid or Ativan. Every fall prevention policy I've ever reviewed requires a reassessment of fall risk after these medications. The logic is obvious. Narcotics and sedatives impair balance, cognition, and coordination. A patient who was a moderate fall risk before the medication is now a high fall risk after it. But here's what actually happens. The nurse scans the medication, documents the administration, and moves on. The fall risk reassessment field in the EHR sits empty. Not because the nurse doesn't care, because she has 14 other patients, and the EHR requires 17 clicks to complete the reassessment, so it doesn't get done. And when the patient falls 2 hours later, that empty reassessment field is the first thing the plaintiff attorney finds. The second most common failure is the hourly rounding log. Most hospitals use paper or electronic rounding logs, where nurses initial that they checked on high-risk patients every hour. In case after case, the pattern is the same. Rounding is documented consistently during the first half of the shift, then it stops, usually around 11 p.m. or midnight. The fall happens at 2 or 3 a.m. The plaintiff attorney doesn't need to prove the nurse didn't round. The empty log does that for them. And here's what makes it worse. Some nurses backfill rounding logs after a fall. They go back and initial the times they missed. Plaintiff attorneys look for this: the ink analysis, the uniform handwriting for entries that should have been written hours apart. It creates a credibility problem that's worse than the gap itself. Third, the bed alarm. Your policy says high-risk patients get bed alarms activated, but most EHR systems don't have a specific field for documenting bed alarm activation. So where does it get charted? Sometimes in a nursing narrative note, sometimes in an intervention checklist, sometimes nowhere. If there's no documentation that the alarm was activated, the plaintiff's assumption and the jury's assumption is that it wasn't. And you cannot put a nurse on the stand 18 months later and expect her to remember whether she turned on the bed alarm for one specific patient on one specific shift. Let's talk numbers. The average hospital fall with injury results in $6,000 to $14,000 in additional care costs. But when that fall becomes a lawsuit, the average settlement for a fall-related medical malpractice case ranges from $400,000 to over $2 million. And fall cases settle more often than other malpractice cases because the documentation gaps are so clear and the policy violations are so easy for a jury to understand. So what does a defensible chart look like in a fall case? It's not complicated, it's just consistent. Fall risk assessment on admission with a score. Reassessment documented at every shift change. Reassessment documented after every narcotic, sedative, or condition change. Interventions documented as implemented, not just ordered. Bed alarm, non-slip footwear, call light placement, all charted. Hourly rounding log completed for every hour, every shift. And if the patient does fall, immediate documentation of the event, the assessment, the interventions, and the physician notification with a documented response. A chart like that doesn't guarantee you won't be sued, but it makes the case almost impossible for a plaintiff to win, because now their 5-sentence jury story falls apart. The hospital had a policy. The policy was followed. The documentation proves it. If you're a risk manager, here's what you should be doing right now. Pull 10 fall cases from the last 12 months, not the ones that became lawsuits, all of them, and run each chart against your fall prevention policy. Every requirement. Did the admission assessment get done? Was there a shift change reassessment? Was there a post-narcotic reassessment? Or interventions documented as implemented? Was the rounding log complete? You're going to find a pattern. And that pattern is going to tell you exactly where your documentation is failing before a plaintiff attorney tells you. This isn't a quality improvement project. This is litigation prevention, and it takes one afternoon. If you're a defense attorney handling a fall case, the first thing you should request is the hospital's complete fall prevention policy and every version that was active during the relevant time period. Then, map every policy requirement against the chart. Don't wait for the plaintiff to do this in discovery. Know your exposure on day one. And look for the compliance points too. Assessments that were done, interventions that were documented, rounding entries that are there. The chart usually has both good and bad. Your job is to find the good before the plaintiff buries it under the bad. Your fall prevention policy is only as strong as the documentation that proves it was followed. Right now, in most hospitals, that documentation has gaps. Not because nurses don't care, because the systems aren't designed to make compliance easy. And until someone audits those charts against the policy, those gaps sit there, waiting for a plaintiff attorney to find them. The question isn't whether your hospital will have a patient fall. It will. The question is whether the chart will show that your staff did everything the policy required. That's why your fall risk assessment policy isn't protecting you. Not because the policy is bad, because the documentation doesn't prove it was followed. If you're a risk manager, audit your charts this week. If you're a defense attorney, request the policy before you request the expert. Subscribe to ChartShield for weekly deep dives on documentation risk and litigation prevention. Visit chartshield.ai to learn how we help hospitals find the gaps before a plaintiff attorney does.